welcome back everyone to today's Explainer. Look, we are jumping straight into it today. We're embarking on a PhD level, exam-critical taxonomic masterclass on the ADA 2024 Clinical Practice Guidelines for Diabetes Classification. We are moving way beyond the basics here to deliver a complete, high-yield breakdown of literally every pathobiological category of this massive, globally prevalent disease. So if you're prepping for the boards or just stepping onto the wards, consider this your definitive framework. Okay, let's dive into this. We are going to systematically unpack 6 major categories today: ADA 2024 diagnostics, type 2 pathophysiology, type 1 autoimmunity, hybrid phenotypes like KPD and LADA, monogenic diabetes, and finally, secondary and rare syndromes. Let's get right to it. Starting right off with Section 1, ADA 2024 Diagnostics and Guidelines. Now, looking at the foundational criteria, you've got to note immediately that routine screening now starts at age 35. And these diagnostic cutoffs, they're incredibly rigid. Normal fasting glucose is strictly under 100 milligrams per deciliter. Prediabetes ranges from 100 to 125, and frank diabetes is 126 or higher. A 2-hour postprandial glucose of 200 or more, or an HbA1c of 6.5% or higher, totally confirms the diagnosis. You also have the random glucose metric, 200 or greater, paired with the classic symptom triad of polyuria, polydipsia, and weight loss. Crucially, polyphagia has actually been de-emphasized in modern teaching. And keep in mind, while HbA1c is a really reliable average, it doesn't measure time in target. It's also super vulnerable to false alterations. For instance, something like hemolytic anemia or chronic liver disease, that's going to falsely lower your HbA1c, but iron deficiency, that'll actually falsely elevate it. So keep an eye out for that.
But before we even get to overt diabetes, we're looking at metabolic syndrome. And here's where it gets interesting. Contrasting the global ATP3 criteria with the vital Indian-specific modifications reveals some very distinct phenotypes. For the Indian phenotype, the waist circumference threshold drops significantly to 90 centimeters for men and 80 for women. A BMI over just 23 is considered overweight. This entirely defines diabesity and adiposopathy in this specific population, which is characterized by hyperlipidemia, high CRP, low adiponectin, and a highly prothrombotic state. Note that while triglycerides over 150 mark the syndrome, it's actually a threshold of 450 milligrams per deciliter that specifically triggers the use of fibrates, like fenofibrate, to prevent pancreatitis.
Moving right along to Section 2, Type 2 Pathophysiology and Comorbidities. Look, while hyperglycemia is the universal phenotype of all diabetes, in type 2, insulin resistance is the absolute, undisputed kingmaker. We used to look at this through a really simple 3-pillar model: increased hepatic gluconeogenesis, impaired skeletal muscle glucose uptake via GLT4, and defective pancreatic beta cell secretion. But our understanding has exploded since then. Centripetal obesity initiates the ominous octet, where abdominal receptor shifts activate hormone-sensitive lipase. Free fatty acids just flood the portal circulation, but they totally fail mitochondrial entry because carnitine palmitoyl transferase expression drops, driving this massive lipotoxicity. Then we add gut incretin defects, renal SGLT2 upregulation, brain neurotransmitter dysfunction, and excess glucagon. It's like a giant puzzle. And the model expands even further to the dirty dozen, adding low dopamine, low vitamin D, hypogonadism, and RAS activation. Finally, we reach the treacherous 13, implicating serotonin and activating lipotoxicity, and the faithless 14, marking toxic iron accumulation, directly destroying those beta cells. So what does this all mean? Well, it translates to this relentless timeline. It kicks off with metabolic syndrome and central obesity, which triggers lipolysis. This rapidly generates hypertension and dyslipidemia. Only much later do we actually see impaired fasting glucose and eventually a formal diabetes diagnosis. This sequence dictates a stark clinical reality. Life-threatening macrovascular complications like atherosclerosis and non-alcoholic fatty liver disease frequently precede the formal diagnosis of diabetes. And because of that early, heavy macrovascular burden, the ADA guidelines have dictated a massive priority shift. Pure glucose lowering, that's no longer the sole primary goal. We heavily favor GLP-1 receptor analogs and SGLT2 inhibitors now for their proven cardiorenal benefits. In the pre-diabetes phase, metformin is now strongly indicated for high-risk profiles, like anyone with an HbA1c over 6% or a history of gestational diabetes. Now, as for pioglitazone, it's highlighted for stroke and cardiovascular reduction via PPR gamma pathways. But in practice, we have to carefully weigh this against its known risks, right? Like bladder cancer, osteoporotic fractures, and fluid retention. All right, shifting gears to Section 3, Type 1 Autoimmunity and Genetics. Now, with type 1, we are fundamentally dealing with B-cell and T-cell mediated autoimmune destruction. So diagnosis heavily relies on a package testing approach for autoantibodies. GAD, or glutamic acid decarboxylase, is the most sensitive and boasts a massive 99% specificity. Islet cell autoantibody, or ICA, is typically the absolute earliest to appear. Insulin autoantibodies are common in new-onset cases, but keep in mind they become entirely invalid once exogenous insulin therapy begins. We also test for zinc transporter 8. And remember, clinical disease only manifests after 70 to 80% of beta cell mass is irrevocably lost. That's huge. And it's often followed by a transient honeymoon phase, lasting roughly 3 years due to residual beta cell function.
If you're prepping for the boards, you have got to be able to contrast these presentations rapid fire. Type 1, think acute osmotic symptoms, sudden weight loss, and frequent diabetic ketoacidosis, marked by a total deficiency of insulin. Type 2, on the other hand, presents with early insulin excess driving resistance markers, obesity, acanthosis nigricans, polycystic ovary syndrome, and hyperuricemia, usually backed by a very strong family history.
Genetically speaking, type 1 is tightly linked to specific HLA types. HLA-DRB1 times 04, that is a remarkably high-yield positive exam association, whereas DRB1 times 15 is actually protective. Interestingly enough, despite it being an autoimmune disease, identical twin concordance for type 1 is only about 40%, which is drastically lower than the 70 to 90% we see in type 2. Parental risk is also surprisingly lower, ranging from just 5% if one parent is affected, up to 15% if both are.
Next up, Section 4. Let's get into the hybrid phenotypes, KPD and LADA. Now we are stepping into the gray zone. These are the hybrid phenotypes, sometimes called type 1.5, and this brilliantly illustrates the paradox of crossing traditional boundaries. First, let's look at ketosis-prone diabetes, or flatbush diabetes. This is fundamentally type 2 physiology, but it presents explosively with ketose, just like type 1. These patients are obese, antibody negative, and they start on insulin but often transition off to oral agents. Then you have LADA, latent autoimmune diabetes in adults. This is the exact opposite. It's type 1 physiology presenting with an insidious type 2-like onset. They're typically leaner, older than 30, and antibody positive. They might start on oral agents, but they will inevitably fail and absolutely require insulin as their beta cells decline.
So, how do we definitively tell these apart? Fasting C-peptide levels. A normal range is 0.3 to 0.6 nanomoles per liter, and just multiply by 3 if you need nanograms per milliliter. A level below 0.3 with positive antibodies guarantees type 1. A modestly preserved but low C-peptide with positive antibodies, diagnosis LADA. A preserved or high C-peptide with negative antibodies points us squarely to type 2 or MODY.
Moving on to Section 5, monogenic diabetes, specifically the MODY subtypes. Okay, so MODY. This is not your typical polygenic insulin resistance or autoimmune destruction. It's a strict single-gene defect characterized by autosomal dominant, mild, and critically non-progressive beta cell dysfunction. The classic board vignette is this: a healthy, non-obese 25-year-old guy with an incidentally discovered fasting glucose around 180. He has a father and a grandfather with diabetes, all perfectly managed on low-dose oral agents without ever developing severe micro or macrovascular complications. The defect simply causes the beta cells to produce inappropriately low insulin for the ambient glucose level. For the exams, you absolutely must memorize these specific MODY subtypes. MODY 3, which is caused by an HNF1 alpha defect, is the most common variant, especially in India. MODY 2 is unique. It's a glucokinase defect present from birth and typically requires absolutely no pharmacologic treatment. MODY 1 involves HNF4 alpha, MODY 4 is an IPF1 defect, and MODY 5 is highly tested because it structurally manifests with renal cysts and genital anomalies. And finally, Section 6, secondary and rare syndromes. All right, to wrap things up, we're exploring the secondary, rare, and honestly deeply mechanistic offshoots of hyperglycemia. Now, what's really interesting about this slide is the elegant yet totally destructive pathophysiology of type 3A diabetes, which links insulin resistance to Alzheimer's disease. The mechanism relies on the insulin-degrading enzyme, which clears both insulin and amyloid beta in the brain.
In a state of peripheral insulin resistance, excess insulin floods the system and competitively saturates this enzyme. Consequently, amyloid beta clearance plummets, allowing neurotoxic amyloid plaques to accumulate and drive Alzheimer's pathology. It's a fascinating, albeit scary, shared pathway.
Then we have type 3C, which is pancreatic diabetes. Obviously, things like cystic fibrosis and hemochromatosis are causes, but the classic exam focus here is tropical chronic calcific pancreatitis, or TCCP. The patient is typically a young, lean male presenting with a triad of abdominal pain, steatorrhea, and ketosis-negative diabetes. Imaging reveals massive fibrocalculus, large duct calculi, and marked fibrosis, which carries a super high risk of pancreatic cancer. Diagnosis is ultimately confirmed via the gold standard, ERCP.
Type 3D covers drug-induced triggers. You've got your pharmacological culprits, like the anti-cancer drug L-asparaginase, and absolutely crucial to remember, the immunosuppressant tacrolimus. Exams love to test tacrolimus over cyclosporin, while noting that drugs like mycophenolate mofetil do not cause diabetes. Other major triggers include olanzapine, which is notorious for severe metabolic syndrome, alongside thiazide diuretics, nicotinic acid, statins, and beta agonists. We also need to recognize type 4, or mild age-related diabetes, MARD. This is way distinct and much less aggressive than classic type 2. The prototype is a leaner patient diagnosed around age 65, easily managed on oral agents. Pathobiologically, this delayed onset is actually driven by a protective surge in specific T regulatory cells, expressing CD3, CD4, CD25, and FOXP3, which suppress the typical rapid metabolic decline we usually see. So we're going to wrap up with a bit of a provocative thought here. When you consider the 14 pathobiological defects of type 2, LADA, the rare insulin receptor mutations in Rabson-Mendenhall syndrome, or the heavily tested genetic links in Friedreich's ataxia, diabetes is absolutely not a monolith. The defining question for the focused learner is this: are we merely prescribing drugs to lower an HbA1c number, or must we actually decode the unique metabolic, genetic, and autoimmune fingerprint of every single patient to truly treat them? Keep that framework in mind as you move to the wards. Thanks for joining me on this deep dive, and I'll catch you in the next explainer.